Okay, guys, this is a short little PowerPoint about diagnostics. Okay, the first thing, electrocardiogram, ECG, or EKG. Okay, it's something that we're very familiar with, even if you haven't had it done before to you. I'm sure you've seen other people have had it done. It's just generally a 12-lead EKG. The test shows the electrical activity of the heart, shows if there's any arrhythmias, and it also can show heart damage. This is one of the telltale things that we do when somebody comes in with chest pain. We can decide, figure out, whatever you want to say, diagnose if they are having a STEMI or what we would call a myocardial infarction, heart attack, that kind of thing. There's no pre-procedure or post-procedural considerations with an EKG. You can come in, get your EKG, and go home. There's nothing left to do. There is no need to get consent with an EKG either. Stress test. Stress test is what we basically call what it is. It is to stress your heart. Okay, it's done either in a treadmill or a bike. Your doctor monitors your breathing and your heart rate and your blood pressure. Okay, what we're trying to do is stress the heart enough so that if there's any kind of narrowing or blockages in your heart, we can tell with that ECG that we're doing why you're taking the test. Okay, it's relatively safe procedure, but we can. It's not a no. It's not. How can I say? It's not. We've had patients that have come in for a routine stress test. Then they go for a cardiac cath because there's something on that stress test, and the next thing you know, they're in the operating room getting a coronary biograph or coronary graft surgery, bypass graft surgery. We can use, and we'll learn a little bit later, that we can use special medicines. So if you're unable to walk on a treadmill or on a bike, use a bike, we can give you medications such as dobutamine to cause your heart to stress. Pre-procedures, MPO. Okay, I believe ATI does not say you have to be MPO, but what I understand is from all of our hospitals around here, the patient has to be MPO. We also hold rate controlling medications, beta blockers, calcium channel blockers. If they're on digoxin, anything like that, we hold it. The reason being, we want the heart to be stressed. These medications help the heart not be stressed, if that makes any sense. So we want it to be stressed. We want it to work as fast as it can. Okay? Hold diabetic medications. We don't know how long the patient's going to be NPO, so we hold all the diabetic medications. Metformin, Novolog, anything like that. Also, they're to wear comfortable shoes and clothes. Okay? They're going to be walking on a treadmill. They're going to be using an exercise bike. We want them to be comfortable. Post-procedure, nothing. Okay, they can go home, they can go to Cracker Barrel and eat some turkey dinner or whatever they want to do. One thing I do want to mention for the stress test, you don't want to give, if your patient's in the hospital, we don't want to give them Lasix before they go to the stress test, or Lasix or a laxative or anything like that. Okay, it'll be very uncomfortable for them. Echocardiogram, also known as an echo. It's a non-invasive test, and basically it is an ultrasound of your heart. We're looking at the chambers, we're looking at the valves, we're looking at the structure of the heart. Well, also what we can do is we can look at the blood flow through the heart. And one of the fun tests that we get to help the ultrasound techs with is called a bubble test. And what we do is we take 3 milliliters of oxygen. So we take a 10 ml syringe, we put 3 mLs of oxygen in it, or not oxygen, air, and we have a stop clock, and then we have an empty syringe, and with that stop clock we put it on so it can't go to the patient, and we start going up and down with our syringe to cause bubbles. Okay, so if you imagine, go back and forth, so we agitate the the air. And then all of a sudden, what we'll do is when the ultrasound tech says go, we'll switch that top stopcock and push that air through the line, okay, into the heart, and they can see if there's any regurgitation happening because of the bubble test. Really kind of cool. You know, all through nursing school, we tell you, don't get any air in those lines. Don't get those air. No air in your IV lines. And here we are putting 3 mLs in there for a test. So just to let you know, it takes an awful lot of bubble or a lot of air to really hurt your patient when it comes to having air in your IV lines. Do you know how much air is in a normal like primary tubing? What do you think? 10 mLs. It takes generally 10 mLs of air to really cause any damage. Okay, for your echocardiogram, no pre-procedural or post-procedural considerations. If they go to the Blues game, they can go to the Blues game beforehand, and they don't have any they can eat and everything like that. Also, want to know, and you're going to find out with the MIs, is that we generally, after somebody comes in with chest pain, the day after we go and we look at their echo to see if there's any structural damage because of stress pain, because of the chest pain. Sorry. Okay, TEE. TEE is basically an ultrasound of the back of your heart. So what we do is we take the probe, and when we go behind your heart, we go down to the esophagus to the back of the heart, and what we're looking for is any abnormal tissues or any heart valve problems, or also if there's any clots. So a patient that has AFib, if they don't know when their AFib has started, what we want to do is we want to look to see if there's any clots before we cardiovert them into sinus rhythm. Okay, so if you can imagine, the patient's under conscious sedation. We numb the back of their throat so they don't have that gag reflex. So they're going to be pre-procedure, they're going to be MPO. We're going to hold all diabetic medications. We're going to get some blood tests, CBC, CMP, because we want their electrolytes to be okay, right? And we also don't want to start this procedure if they have a high white count. Post-procedure, we're going to check their gag reflex. There's 2 things in nursing that I really don't like doing. One is putting an NG tube down. I think that's just a horrible experience for the patient to put an NG tube down and then to keep it there for several days. Another one is checking the gag reflex. So how do we check the gag reflex? Well, we go and we get one of those tongue depressors and put it down to the back of their throat. And if they gag, they can eat. That's the only safe way to make sure that they do have the gag reflex. With this procedure, you also want to have a side consent, okay? Due to the fact that we are conscious sedating them, so it's a kind of an invasive procedure. Okay, myocardial perfusion test. Remember I told you about the stress test if you're unable to walk or ride a bike for the stress test. What we're going to do is we can do what we call a myocardial perfusion test. It's considered a nuclear scan test. And we can... Sorry about that. A kid bothered me. I don't even know where it was. So, remember when we were talking about the dobutamine. This is a stress test that if you're unable to exercise, we can give you dobutamine that will stress your heart. Dobutamine is a medication that we use to increase patients' heart rates, and this is what's going to do. For the pre-procedure, it's MPO, and we also hold the diabetic medications because we don't know when they're going to be able to eat again, so we don't want them to bottom out on us. Post-procedure, really nothing. This is a nuclear scan, so what's going to happen is they take pictures before, then they give them some nuclear medication, they send them back up to the room, then they come back, and that's when we give them the dobutamine, and they take pictures then, and then we'll send them back up, and then they'll come back down another hour to see how it's changed from the time before we give them dobutamine to the time they get dobutamine to after they get dobutamine to see if there's any problems with the heart and the structures. Remember, this is looking to see what parts of the heart is not getting enough blood. Okay, Halter Monitor. For this test, it's usually between 24 and 48 hours. Um, and we ask you to go home and do normal activities. At the end of the time period, we return the monitor and to the doctor's office so it can be evaluated. While they have this monitor, they can't take it off. They can't take a shower. We ask that they just do normal things. Now, I was having some issues, and so they put a Halter monitor on me because I was having some, I wouldn't say chest pain, but it was let's just say chest discomfort. Anyway, so they wanted me to do the Halter monitor. So no problem, I did it, and then I tried to give myself a stress test. I figured if I did it and I did and I worked with it, that I could get my heart rate high enough that it would be considered a stress test. Yeah, that didn't work. Yeah, I still had to do the stress test, which was negative, but it was kind of interesting. I did try to get away from it, but now I still had to pay it. But anyway, event recorder. Event recorder is a small operated. It's similar to the Holter monitor, but now it's really kind of gotten really high tech, because now we can actually use it towards your phone. It's not as big as a Holter monitor. Holter monitor you have to have around your neck, kind of like a telepack. But with the event recorder, it's now part of their phone, or they have something similar to a phone that they can that's wired near them. Every time they have an event, if they have a syncopal event or if they feel fluttering in their chest, they can record it. They hit the button, and it records that they're having that, and then it gets sent to the doctor's office. Usually, some people that have event recorders are on for a couple of weeks. A loop recorder is really kind of different. For a while, we haven't seen any, and then like a year ago, we inserted 4 of them. What they do, it's a surgical thing that we do. Well, we don't do, but they do in surgery, and they put it in. It's kind of like a Holter monitor or an event recorder, but it's underneath the skin, and it monitors your heartbeats for up to 2 years. I found that when people are a little bit younger, they use this loop recorder if their family that has a history of cardiac disease. They'll put that into them to monitor, to make sure that they're not going down that same road. So, but yeah, it was kind of weird that we were doing so many in a short time. Tilt table test. The doctor will connect you to an EKG and a blood pressure monitor, and it actually, you lay it on the table and it tilts you from a lying to a standing position. This is a safe way to make sure or to diagnose if you have orthostatic hypotension. Usually it's with older people that we do this with, and it's just a safe way so that, if we try to get them up, they don't have a syncopal episode. It also shows slow pulse rates with positional changes, so we can diagnose that also in a safe manner. Cardiac catheterization. Okay, the reason we would do a cardiac catheterization is a couple reasons. A, you come in and you have a chest pain, and we want to go in there and basically alleviate the blockages. B, because you had a stress test and you showed some ischemia. One thing I didn't mention about the stress test is what we're looking for is while you're exercising, if there is an ST depression. A depression shows that there's not enough blood to get through the heart. Okay, so your heart is kind of, I don't want to say starving, but there's just not enough blood or oxygen-rich blood getting to the muscle of the heart. With cardiac catheterization and a STEMI, that's what we're looking for is an ST elevation, which don't get locked into these terms right now, but an ST elevation shows that there is an infarct in your heart, which means no oxygen-rich blood is getting to that part of the heart. So how do we do this? Well, we can either go through the femoral artery or the radial, and there's a hollow tube, and basically they put dye through the catheter, and then they take x-ray pictures as the dye is going through your heart. Okay, it can show any narrowings, it can show the chamber size of the heart, it shows how the heart is pumping, and as well as the valves being open and closed. And they can also measure the different pressures in your heart. Okay, and when we get through to when the STEMIs and myocardial infarctions, we're going to talk about how they can help a patient who has a narrowing. PreProcedural Considerations, NPO, allergies to fish, because we are using dye. Okay, they do need to have a signed consent. 12 EKG. Now, of course, if they're coming in through the ER because they have are having chest pain, they already have an EKG. But if they're coming in as an outpatient, maybe they want to have a procedural, maybe gallbladder surgery, and they're older, they'll get an EKG. And I'm sorry, then maybe they'll have a stress test beforehand. And it's showing, well, something's a little wonky there. They'll schedule them for a cardiac cath. Before we start the procedure of the cardiac cath that morning, we're going to get a 12-lead EKG. We want to see what the heart's doing before we go and mess with it. Blood tests, a CBC and a CMP. Okay, the CBC, we don't want them to have any kind of infections. We want to know what's going on in their blood. And a CMP, we're looking for electrolytes. The one thing we don't want is to have any electrolyte imbalances before we go into any procedures. We do give them a 325 aspirin. Okay, that is standard for all patients. We do not give them diabetic medication, and metformin is held for 72 hours after the procedure. Okay, it is important that we hold it because the contrast and metformin just doesn't mix. Okay, we don't want to cause any damages to the kidneys. We also know laxatives or diuretics. The last thing you want to do is have a patient is laying flat on a table with a scope into near their heart to have to pee or poo. Hold Lovenox. Lovenox, remember, is a long-acting anticoagulant, so we want to hold that. We can give heparin because of the short half-life of it. Plus, whenever we put that cath into their groin or into their wrist, we actually flush it with heparin. Okay, and we're going to hold any anticoagulants for 5 days before the procedure. So Eliquis, Coumadin, Pradaxa, any of those we're going to hold. Adverse effects while bleeding, inner and outward signs. So bleeding inward, so we're looking for vital signs. We're looking for pedal pulses, because the pedal pulses are also going to tell us if they're bleeding inside. We'll get to that though. Reaction to the dye, because some people do not realize that they're allergic to the dye. Any kind of kidney damage due to the dye, and what we call a retroperitoneal hemorrhage. A retroperitoneal hemorrhage is a hemorrhage that happens, and it's usually it is manifested by a back. They'll talk about back pain. They will also have a harder abdomen, and basically what they're doing is they're hemorrhaging in their abdomen. But because of the pressure, a lot of times the biggest complaint is back pain. Okay, so for femoral access, we're going to assess the vital signs, puncture site, and pedal pulses every 15 minutes times 1 hour, every 30 minutes times 2 hours, every hour times 2, and every 4 hours times 2, then every shift. Don't get caught up on memorizing every 15 or anything like that, okay? I want you to know that you assess the vital signs, the puncture site, and the pedal pulses. Every time you go in there, you're doing the vital signs. Of course, now we're having a great time with our electronics, and we can set the vital sign machine. But the puncture site, so we're going to go in and we're going to look at that puncture site in the femoral. And is there any oozing? Whenever they come up, it is actually a 2x2 with a tegaderm on top of it. So are they oozing through that puncture site? Okay. Is it getting hard around that site? Which means that there's bleeding happening, but it's just not coming out of the skin. Pedal pulses will show if there is a rupture, I want to say rupture, or it's leaking or hemorrhaging from the artery. So think about it. We're going into the femoral artery. We're going to check pulses before they go down so that when they come up, we know where the pulses are. We actually mark those pulses. But we're going to feel for that pedal pulses. If they have no pedal pulses, then we can probably make a good diagnosis of there's something happening upwards, okay? Means that they're hemorrhaging upwards in their femoral area. So we have to be careful and check those pedal pulses, okay? Because if they don't have blood going to their legs, what's going to happen? Well, A, they could die because they're hemorrhaging and we didn't do anything about it. Or B, if we take our time, they're going to lose the blood flow to their legs. And if they lose the blood flow to their legs, we're going to have to cut it off. We don't want to do that. So, every shift, or every time we go in for vital signs, puncture site, and pedal pulses, okay? They have to lay flat for 4 hours. When I say flat, they can't be higher than 30 degrees. This kills some people, because of back issues. We can do Trendelenburg positioning. We can put it on either side. I usually put let's face it, hospital pillows aren't very fluffy anyway. So I will log roll them and put a little pillow underneath them so they're not right on their back, they're a little bit on their side, but it is a log roll. We got to keep that site with that femoral artery straight, okay? Think about this. The next one is when coughing must get pressure on puncture site. If they're coughing, if they move their leg, they're going to add not needed pressure against that Angio Seal that's stopping the artery from bleeding out. So if they cough, we tell them to put their pressure on that leg. Okay, we ask that they don't move their leg. And what we used to do, which was really good, is we would take a sheet and say it was the right leg that had access. The left leg was, was good. What we would do is we put a sheet over that right leg and tuck it underneath. So the sheet was on top of the right leg, but under the left leg, and we would tuck the sheet underneath the bed so that it was a reminder not to move that leg. Finger foods, they're going to leave flat. It's not a good idea to give them chili or soup or anything like that. So finger foods, a sandwich, hamburger, something to that effect. They can't drive for 2 days. The last thing we want to do is for them to drive and have to hit their brake really hard and dislodge that Angio Seal. Cannot submerge their below the waist. Boy, I never did. Cannot submerge below the waist for 3 weeks. One day we had this guy and we told him, okay, no swimming in the pool, no hot tubs, no baths or anything like that. He came back and his puncture site was infected. And we're like, what happened? Because we never had these issues. And he goes, well, I went swimming in the lake. What? Well, I went swimming in the lake. Why would you go swimming in the lake? Well, you told me not to go in a hot tub or take a bath or anything like that, but you never say anything about swimming in the lake. I mean, seriously, I didn't think he was 3 years old, and we had to spell it out for him. So now, every time I have a patient, I tell them, do not submerge your below the waist for 3 weeks. No part. You can take a shower, but don't submerge it and let it sit. One of the problems is if they decide to go home or when they go home the next day, if they're submerged, that Angio Seal, what happens to your skin? It gets all kind of funky, right? Mm-hmm. It gets a lot looser, and we're afraid that Angio Seal will pop. We will give them instructions about bleeding. One of the things we tell them that if they are bleeding, to put as much pressure, and basically we tell them to go face first. Okay, we tell them to go into prone position because that puts in a lot of pressure on that site, and to call 911 as soon as possible. Swelling or discharge from the puncture site, we will also tell them about, and when to get to the ER as soon as possible. Okay, this is the Angio Seal What it has is this part goes in, bypass tube, facilitates insertion into the sheath, protects the suture, and what this does is it releases a suture below within the artery, and then it puts out some collagen, and that's what this part is, collagen that helps block, so that the blood can't come through the skin on top of the skin. It works really kind of well, okay? We do have some issues. It does leak sometimes, and if it does leak, we put all of our body pressure, all of our body weight onto that Angio Seal, and it's basically you put your fist and you put your weight on it. If you use your muscles to do it, we generally have to hold the weight on there for about 10 minutes. It's a great accomplishment that we even have this kind of Angio Seal. We don't do it. Actually, the x-ray techs do it after the cath is done. Cardiologists don't even do it. It's the x-ray techs that do it. Okay. Before, back in the day, patients would have to lay flat for 24 hours with actual sandbags on their site. We don't have to do that anymore. They have to lay flat for 4 hours, and they have this wonderful thing called an Angio Seal. But sometimes it doesn't work. On your right, where it says number 1, you see a femstop. And what a femstop is you have two, I don't want to say, devices on either side of their hips, and then where the little star is, or punch sign, or asterisk, whatever you want to call it, that's a weight. Now what the lady's holding right here, or man is holding, is the device that puts all the weight in. So with this device, we can say, 20 pounds of pressure or 10 pounds of pressure. And generally what we do is we put enough pressure on there that it will stop the bleeding. Very uncomfortable for the patient. Of course, it's uncomfortable for me to sit there with my weight on top of a patient to stop the bleeding also. But this is also equally uncomfortable. But we usually use this when we have no other alternative for the patient. They just keep on bleeding. If we've tried different Angio Seals and they see bleeding, then we'll put a femstop on there. Okay, the wrist access, same post-op item, vitals, signs. Release the band as ordered. Instruct the patient not to use the affected hand. It's kind of hard because it seems like we always get the hand that they are strong on. So they always want to use it to eat sandwiches and stuff like that. And then we also give them instructions about bleeding, swelling, or discharge from the puncture site. I tend to like the femoral artery better due to the fact that I've not had as many adverse effects with it as with the wrist access. Of course, patients like to have wrist access because they don't have to be flat for 4 hours. They can actually go up to a 40-degree angle, 45-degree angle. So they like the wrist access better. No matter what, they still aren't allowed to get out of bed for 4 hours, which is a common complaint with our patients because that means that they can't go to the bathroom and we're putting a bunch of fluid through them to flush the dye through their kidneys, so a lot of times they're not happy. These are the different wrist access points. The ones that we're used to using is B and E. With B, there is, you see the green syringe, and you see a little pocket. I wish I had a pointer, but I don't have a pointer. Well, it says I have a pointer, but you guys said that pointer. Let me do a highlighter. Okay, so right here, what that is it's almost like a balloon, so to speak, and that goes on the puncture site. So we'll have the air in the syringe, and it might be, let's say, 10 mLs. Okay, we put enough air in there, so yes, you're still getting blood flow to your fingers, but it's restricted. Okay, so you're getting blood flow, but your hand's a little bluish, let's say. What we'll do is we'll take that device off as time goes on. So maybe we'll take 3 mLs off. We'll attach the syringe to this area right here, and we will release 3 mLs. Now, with this syringe, you make sure that you put it on the table away from the patient. The last thing we want is to keep the syringe attached to this and for that to be totally deflated and then the patient start bleeding. Not a big fan, I have to say. I'm not a big fan because if the patient starts bleeding again, you have to put the little, I guess you call it a bladder, little bladder on top of the site, and then you have to air it up. When your adrenaline's going because it's bleeding so bad, it's a little tough. Now E is my favorite. It's actually like a zip tie. See these little, if you can see better here, they're little rib things. It's just like a zip tie. This part right here goes right against the patient's insertion site and you zip it shut. Okay? As time goes on, as the patient's up in their room, we'll release like 3 clicks, maybe every 15 minutes until it's very loose on the patient. Now what I really like is generally we keep this on the wrist for several hours. So if the patient would, I don't know, like hit the wrist at that point, all we have to do is put it next to that area, okay, with the puncture site and zip it shut. I really like this a lot better. I've not seen these other ones being used. I'm sure maybe somewhere. I mean, it looks kind of cool. Like this F1 looks kind of cool. But this is what I know SSM uses. Okay? Okay. MRI. Okay, basically it's an MRI. We're looking for how the major vessels, the heart valves, we can detect coronary disease, we can see narrowings, we can see everything about it. Problem with it, A, it's really expensive, B, it sometimes takes a while depending on what we're looking at. It's not really good for, a patient that's having a chest pain. That's not what we're going to use it for, okay? If a patient's maybe wouldn't be able to tolerate a cardiac cath, we possibly would use an MRI. Okay, the one biggest thing about the MRI is the MRI questionnaire. It's maybe 35 questions, and we need to know if they have any problems with any metal in their body. If they worked in a metal shop, if they've been shot, if they've had tattoos before the year like 1960. I guess they put metals in their tattoos. Now we have to worry about eyelashes, because the eyelashes, fake eyelashes, have metal in them. So there's the whole procedure, the whole questionnaire is so that patient doesn't go in there and has an adverse effect because of the magnetic pull. And last but not least, cardiac CT. It's an imaging, uses X-ray machine and computer to see a 3D image of the heart. Sometimes a dye is injected, sometimes it's not. We can use it also in case the patient is not able to get a cardiac cath. Okay, there you go. Kind of short and sweet, kind of not short and sweet, but there's the download and getting the diagnostic tests.